grateful. If I may, let us pray. Eternal Father, bless our land. Guide us with thy mighty hand. Keep us free from evil powers. Be our light through countless hours. To our leaders, great defender, grant them wisdom from above. Justice, truth, be ours forever, Jamaica, land we love. Lord and Heavenly Father, you have brought us together in this place for such a time as this. You guide us, you lead us, and you show us the way we should go. And so, Lord, we just want to ask your blessings on today's proceedings. We discuss the matter of the COVID-19 infection in children. We thank you for those who have made themselves available for this meeting. We thank you for all those who are in the meeting and all who will participate. I thank you, God, that at the end of this, we will be wiser and we will be empowered so that we will do the right thing as it relates to this infection. Lord, be with us even now. Cause the different difficulties that we're having technically to be sorted out. And we thank you, God, that you have given us this opportunity. Bless us even now, and we pray for the persons who will deliver their presentations and who will discuss the matter ahead. This we ask you in Jesus' precious name. Amen. Without further ado, I do see Dr. Besseser Mackenzie, and I would like to welcome our Chief Medical Officer, the Captain of our ship, to welcome us at this time. Dr. Besseser Mackenzie, please go ahead.
Hi, good afternoon, everyone. Well, I want to add my own welcome, and I'm happy to see the participation that we're seeing from both locally and from persons overseas. I want to thank the Health Services Planning and Integration team who have put this together, and for all the presenters who have agreed to participate. Jamaica has over 2018, 2019 been struggling, as a lot of persons know, to manage an epidemic of dengue, which severely affected our children in particular. And so at the start of this epidemic of COVID-19, I think many persons were relieved at the beginning to see that children were not as affected as in dengue. But as time has passed, we have seen this disease evolve, and we have now noted that there are several changes that have occurred since the start of the epidemic. And in particular, we're now noticing that younger persons are being affected. And recently, we have seen the case studies that have been highlighted with this new multi-system inflammatory disorder. So we are very anxious to hear about this new entity, and I would not say anything further because I know that everyone is just anxious to hear what's happening and how it is that we can prepare ourselves to manage this, just in case we have cases to deal with. So I'm over to you, Nadine.
Thank you, CMO. It's very encouraging to see you. Go ahead. Yes. It's very encouraging to hear you. It's very encouraging to see you. And you have hit the nail on the head, like us all. We're very excited and eager to hear what it is that is going to be said. At this time, I will welcome our Dr. Iana Wellington, who is almost our go-to person many times in the Ministry of Health and Wellness as it relates to matters epidemiologically related. At this time, I'm really grateful that she would have taken some time on her Sunday afternoon to be with us. And I will ask, without further ado for her to share with us this matter of the epidemiology of pediatric COVID in Jamaica. You would have heard the Chief Medical Officer speak to what we initially had anticipated, but now it's so much more has been observed. And so I will ask Dr. Wellington to share with us epidemiology of pediatric COVID-19 in Jamaica.
Thanks, Dr. Williams. Just checking. Good afternoon, everyone. Just checking if you need for me to share my screen or if the presentation is good.
I think you could share your screen if you may. We do have your presentation, but some technical hitches. Please go ahead and share your screen.
Okay, just a minute. All right, just checking if you're seeing my screen.
We are.
Okay, right. Okay, so this is as at yesterday for the most part. So in summary, I'm just going to summarize the situation, the current situation overall, and then we'll get into some of the details of the under 18, those under 18 years old. As at yesterday, we had a total of 550 confirmed cases of COVID-19 in Jamaica, and this is a summary. 62 of these were imported, 27 were local transmission, not epidemiologically linked, 211 were contacts of confirmed cases, 235 were identified as part of a workplace cluster, and 15 were under investigation. Of note, roughly 12% or 66 of these persons were between 0 and 8 years old. 35 of these were females and 31 were males. Overall for Jamaica, again, we've done a total of 9,923 COVID-19 tests as at yesterday. 550 of these were positive, as you know, and we had a 5.5% positivity rate. As far as the distribution of cases over time is concerned, we have noticed that around the middle of April is when we saw the largest number of cases to date. As persons would have heard, we had a couple of days where no cases were confirmed. Bear in mind, however, that this epidemic curve is showing the number of cases by date of onset, not by date of confirmation. So you will see that the date of onset, the largest number of cases was seen on the 16th of April onset, and the numbers decreased daily to just about a few days ago when we started to have a few more cases, most of which were imported cases. Again, this is showing the rate at which the rate of increase of cases, and at this point we're basically tracking at 10 to 15 day doubling. The reproductive rate is currently being recalculated with the new number of cases. So this was as at a few days ago. We had overall a secondary reproductive rate. So this is a primary case infected roughly 1.6 persons. As far as the geographic distribution of cases is concerned, the number of cases, the rate, we look at both the number of cases as well as the number of cases per 100,000 population by parish, bearing in mind that different parishes have different population sizes. So the largest number of cases so far has been from St. Catherine, followed by Kingston and St. Andrew. The parish with the third largest number of cases is Clarendon. However, when we look at the rates per 100,000 population, St. Catherine has the highest rate, followed by Kingston and St. Andrew, followed by St. Mary. Oh. Right. We also look at the number of confirmed cases that have been identified in each statin community. So this is a community map showing the number of cases identified in these communities as at 2 weeks prior and currently. So you will see that for Jamaica generally, the number of cases has remained steady per community except for St. Catherine. As far as the speaking specifically to those under 18, as far as the transmission patterns are concerned, we have noticed that roughly a half of the children were asymptomatic at the time of diagnosis, and most of them were contacts of a confirmed case. So they were picked up by contact tracing. 1 was an imported case, and 4 were local transmission, and they were not epidemiologically linked to other cases or to another country. So these cases are primary cases, so they're index cases, and they start a chain of transmission. As far as the symptoms are concerned, this was as at when we had 59 cases. This analysis was done when we had 59 cases. Like I said, most were asymptomatic. The symptoms that we most commonly saw, and most children who were symptomatic, the symptoms were mild. So the most common symptom was cough, cough and fever separately. And we also had reports of headache, runny nose, and in some symptoms such as anosmia and loss of taste. Overall, we have had 9 deaths, and one of these deaths occurred in a child. Most deaths, as would be expected, occurred in persons with comorbidities. That child had comorbidities as well. And most deaths occurred in older persons, especially in those above 65 years old. As far as the severity of illness is concerned, most children, like I said, had mild disease. However, there was one child who had severe disease and who demised. As far as the outcomes are concerned, 14 of those who were between 0 and 4 years have actually recovered or have been documented to have had 2 negatives, asymptomatic, and have been classified as recovered. 24% of those 5 to 9 years have recovered. 27%, so it's roughly a quarter of those in the other age groups who have recovered. 4 out of the 15 aged 10 to 14 years have recovered. 2 out of the 8 persons aged 15 to 17 years have recovered. This is just going into community transmission a little bit, telling you about our respiratory surveillance. So we have systems for capturing routine surveillance of acute respiratory infections. This would capture persons who present to health facilities with an acute respiratory infection, whether as an outpatient or if they're admitted. To date, we have picked up 43 confirmed cases through this type of surveillance, with the largest number of such cases being seen in week 16, of 2020 so far. So when we speak of local transmission, not epidemiologically linked, some of these cases are actually children who presented. This data is not for children, it's for all ages. However, when we speak of local transmission, not epidemiologically linked to another case or another country, those are the cases that we tend to pick up through our routine surveillance. They present to the health facility for some reason, and they are, usually for an acute respiratory infection, and they're found, upon swabbing and testing, they're found to have COVID-19. As far as the distribution of our surveillance cases is concerned, or cases that are picked up by routine surveillance, most have been picked up in Kingston and St. Andrew, followed by St. Catherine. So the pattern is somewhat in keeping with the number of cases overall. So in summary, the number of new cases of COVID-19 peaked in the middle of April of 2020 so far, and we've started to see a slight increase again. Most of the cases that we have seen, most of the increase has been due to persons who have been re-entered Jamaica and have been picked up upon initial swabbing. COVID-19 cases have now been identified in all parishes. As far as children are concerned, and I hadn't defined it earlier, but children for this purpose are those between 0 and 18, so 0 to 17 years. Cases in children have tended to be associated with cases in adults. So the children have tended to be picked up through contact tracing of symptomatic or confirmed adults. And most cases in children were asymptomatic or mild. Just a reminder, we've had one death in a child, and that child had comorbid conditions. So that's it. Thank you.
Thank you, Dr. Wellington. This has really put a lot of things into perspective. As the CMO had said, our initial thoughts that children were not affected has not been panned out in our own situation, and we have certainly a number of persons. We would like to take the questions at the end of the presentation. I am not sure if our CMO wanted to say anything at this time, but if not, CMO, would you like to say anything at this time?
No, Nadine, I have to be dealing with some other matters.
Sure. Okay, thank you so much. I do want to welcome at this time a number of persons who are through the Caribbean. I hadn't realized when we started out, but I can actually see a number of persons from Trinidad and Barbados and Grenada, I believe. And I really want to say welcome to our regional partners, as well as our local consultants, bodies, persons in the field, a wide variety of persons. I believe that the Pan American Health Organization is also represented, as well as persons who worked in the field before. So I just like to say welcome. I'm going to ask you to keep your questions for question and answer period. And at this time, I would like you to help me welcome Dr. Tracy Evans Gilbert, who is a consultant pediatrician, who also is a public health specialist, certainly in many ways, and who specialized in tropical medicine. She is a senior associate lecturer at the University of the West Indies, Mona, and I'm at this time going to invite her to share with us her case series of COVID-infected persons, children in Western Jamaica. She is a consultant at the Cornwall Regional Hospital, which is situated to the west. Many persons would remember that is actually in the Montego Bay area. So without further ado, Dr. Tracy, thank you for everything, and thank you for being here. Please share with us your case series.
Thank you, Nadine. Good morning, everybody. I'm very excited to present these cases to you because I've been hunting them down, and I was very delighted to hear that we had a government isolation facility in Montego Bay, and I found some kids there, and I was able to put together something to share with you today to complement what Dr. Wellington just presented. So there are two government quarantine facilities located in the Western region, and we're about to summarize the admissions to these facilities as well as admissions to the Cornwall Regional Hospital. At the end of the summary, I will highlight 3 cases to illustrate the spectrum of disease presentation that we are experiencing so far. So we had a total of 14 children who were admitted. 1 was at the Cornwall Regional Hospital, and 13 were at the government isolation facility. Among those 13 children at the government isolation facility, 8 of them were SARS-CoV-2 positive. And the 5 children who were negative were contacts of confirmed cases who were being quarantined. Their ages ranged from 15 months to 14 years. The following is a summary of the 8 confirmed cases. So this is just an overview of the variables that I was able to get available. Age, their first PCR negative after diagnosis to get an idea of how long they were having viral shedding. To summarize those 8 children, 4 of them were within the 1 to 4 age group, primarily age 2, 2 were in the 5 to 10 age group, and 2 were in the 11 to 16 age group. There was a predominance of females, and the majority of them had a positive contact, as Ayana said. 1 of them had a history of travel, and 2 of them had no immediate contact in their families. The most of the cases were mild or asymptomatic, and 1 critical case that was mentioned earlier. In terms of the prevalence of PCR negative after diagnosis, the median time to PCR negative was 15 days with a range from 7 to 25 days. Just to summarize this small number of cases, not all the children exposed to a positive contact became infected. There was a predominance in toddlers, and I found out the reason was because toddlers usually share the same room or the same bed if mommy was the positive contact. The majority of those who were infected did have a positive family contact, and the symptoms were primarily asymptomatic or mild. We had 1 critical case, and that number would be very low among the total numbers that we're seeing. And we are seeing that the period of viral shedding, as evidenced by the prevalence of a positive PCR, lasted for about 1 to 3 weeks. So these findings are consistent with the published literature. Children are more likely to contract COVID-19 in their households or through a contact with a family member, especially in the countries where they're doing similar to Jamaica, where there's school closures, strict physical distancing are being implemented. And there actually are 2 studies on household transmission that estimates the secondary attack rate to about 16 or 13%, which might explain why not all children who are exposed became infected. As it relates to viral shedding, the studies that are available among adults show that the viral shedding can occur at a median of 20 days, with the longest being 37 days. Some case studies in children show similar time period of clearing of the viral RNA in the upper respiratory tract of about 2 weeks, but also demonstrated a longer period of viral DNA in the stool. Now, whether this viral DNA is viable or not, there have yet to be any studies that show that the viral cultures are positive. So these might just particles from the virus that remain in the stool. And a larger study showed that the shedding patterns of culture competent virus in symptomatic children resemble those that are observed in adults. In this particular short series, we're seeing a shorter period of viral shedding, and it's primarily among asymptomatic as opposed to symptomatic children. And just to say that the presentation is similar to what's seen around the world. Most cases in children are mild. These are large studies in China and the US, with about 5 to 6% requiring hospitalization and up to 2% requiring admission to the ICU. So our pattern seems to be similar, although it's just a small number. We're starting to see a pattern which is similar to what is already published. So I'm not going to highlight 3 cases to show you the spectrum of disease that you are going to see among children. So the first case is a 2-year-old who arrived from overseas after a 2-week visit with his mommy. He was a previously healthy little boy. He was vaccinated against influenza and pneumococcal vaccine, and he was up to date with other recommended vaccine. His mommy, after returning from the overseas, developed symptoms of a sore throat. She had a fever for 5 to 7 days. She had cough and fatigue, and she tested positive for SARS-CoV-2 a week after her arrival, and it was isolated in hospital. The child was reportedly asymptomatic, and he was home quarantined with his dad and his sister. And the 2-year-old was subsequently tested. Child was with his family for 2 weeks. He didn't transmit the virus, and available evidence suggests that child-to-adult transmission is uncommon. There's a study in the first outbreak in France. There's a case just like this where an infected child did not transmit the disease despite being in close contact with other children and teachers. And there are really very few case reports that suggest that there is a child-to-adult transmission, but these are very poorly documented. So far, child-to-adult transmission is not really something that's prevalent. The second case is of a 6-year-old female. She has a past history of sinusitis and recurrent ear infections. She was immunized for age and otherwise well. Her mommy sells in the market, and she presented with a history of fever, sore throat, and earache, which her mommy says is not unusual. This is how she normally presents with her ear infections. So mommy used some home remedies and some over-the-counter analgesics, but her symptoms persisted, and the child progressed to have loss of appetite, drowsiness, and frequent thirst. So mommy went to the doctor after a week. When she went to the doctor, she was diagnosed as having an ear infection, and she was treated with antibiotics. But because she was having influenza-like symptoms, the nasopharyngeal swab was done for surveillance, and she was sent home. She got better. All her symptoms got resolved, but then her test for her sampling came back positive, and she was quarantined with her mom. Her mom subsequently tested negative. In terms of the contact history, there was no travel history in the 2 weeks leading up to the onset of illness, overseas or otherwise, except for a hospital visit via public transport. And this visit to the doctor was after she had symptoms. There was no contact with anyone who recently traveled overseas or who was diagnosed with COVID-19, but there was an indirect contact. A grandfather who lives across the road went to look for his sister who had returned from the UK. But the time from the visit to the symptoms of the child was about 2 incubation period, which was about a month before. Mommy herself is, as I said, visited the markets regularly. The taxi drivers and other immediate family members and contacts were tested, and to date, there are no positive samples. So the most important thing that I'd like to highlight is that this child was detected by sentinel servants for influenza-like illness. She had an upper airway pre-existing condition, but the symptoms were mild and they resolved with the usual intervention. The grandfather is a person of interest, but we have not yet identified a source of her infection. And as I said, her contact with the healthcare facility was after her onset of symptoms. So I highlighted this case just to remind our viewers that surveillance samples may yield some important information. So if you have patients with influenza-like illness, SARI, pneumonias, be sure to do your SARI sampling so that you may pick up something like this. The third case is a 4-year-old child who had congenital microcephaly, porencephalic cyst, and craniosynostosis at birth. He was evaluated for Zika at birth, but it was not confirmed. This baby was immunized for age and had a history of global developmental delay and had 3 admissions in the first year of life for seizures, bronchiolitis, and gastroenteritis. This child had difficulty swallowing and was referred for failure to thrive and was recommended for a gastrostomy tube. And the main things that the child was able to have was cereals and porridge because they couldn't swallow solids. But this baby defaulted at 2 years old, didn't have the G-tube put in. So she first came to our attention at age 4 years old, and she had had 3 visits to the ER for vomiting, hematemesis, and dehydration. She was managed as an outpatient with fluid resuscitation and omeprazole, and they observed her with an NG tube and they didn't see any blood, and they did her labs. Her coagulation profile was normal. She recovered from her dehydration. She was able to swallow, and they sent her home on omeprazole. So it was on her 4th visit, she began developing a fever and noisy breathing, and they thought she had a gastritis and an aspiration pneumonitis. This particular child had no travel history in the 2 weeks leading up to the onset of illness, except for those 3 visits to the ER in a chartered cab. There were no contacts with anyone who recently traveled overseas or who was diagnosed with COVID-19. And again, there was an indirect contact with an uncle from the UK who visited the yard but didn't visit the child. The brother looked for the uncle and came back indoors, but she was not directly in contact. She lives with the mommy and the 2 siblings in a 1-bedroom house. And as I said, the 14-year-old was in contact with the uncle, but neither uncle or 14-year-old were unwell. So this is just a summary of this case. So the main clinical findings on admission were underlying spastic tetraparesis. The child had bulbar palsy and had evidence of dehydration. The child was febrile on admission, breathing about 32. The blood pressures and oxygen saturations were normal. Chest findings were unremarkable, and X-ray findings were unremarkable. The abnormal laboratory values, normal LFTs, but the blood and creatinine were consistent, elevated and consistent with pre-renal failure due to dehydration, and the LDH was also very high. She had a high white cell count with primary neutrophils, no lymphopenia, and she had a blood and urine culture. We did her swab. Even though her chest findings and radiology were unremarkable, we had done her swab because of this history of this noisy breathing and the fever. It was very unclear. It was just a surveillance swab, not because we thought she had anything to do with COVID. So we commenced ceftriaxone and Flagyl for her query aspiration pneumonitis and managed her hydration. So on about day 2, she started actually having respiratory distress, and her oxygen requirements increased. Of note, she had copious secretions. She needed frequent suctioning. And by about day 4, she defervesced and her cultures were sterile. By then, we got back the SARS-CoV test, and it was positive. By about day 7, she had started showing improvement. Her oxygenation requirements became less. Room air oxygen was showing improvement. Her respiratory rate was coming down. But then she took a turn from the worst on day 10. She developed these evidence of sepsis. She had worsening respiratory distress, deranged coagulation profile, electrolyte abnormality, and her secretions became more profuse. We requested other investigations like her CRP and ferritin, but this was not immediately available, and D-dimers were not available at all. At the time, there was no evidence of septic shock. She was recultured, switched to meropenem and clindamycin. We did fluid resuscitation, corrected the abnormalities, got FFP for her deranged PTT, and ICU was called in to help with her oxygenation. We found that when she was nurse prone, that her oxygen would go up in the 90s, but once they suctioned or moved her, she was very brittle, and slight movement would make her desaturate, and she required non-invasive ventilation. But within 24 hours, she had a cardiorespiratory arrest, and the likely cause of death was sepsis or severe pneumonia. And because of her cerebral palsy and bulbar palsy, we thought that this compounded her clinical course. We tested her immediate family, and they all tested negative. This is a child with cerebral palsy that doesn't leave the house. Her mother and her brother and her sister were negative, and the brother, who I said visited with an uncle, was negative. Because this child came to the ER 3 times, we had to test all the emergency room staff and the pediatric staff, who were at various levels of risk, low to high risk, but everybody was negative. There was also another child who was in the room with the patient, and this child was there without a mask. The child was nebulized and suctioned, but that child also was negative. And it highlights what I said before about the risk of transmission from a child. So I got really excited about this not in a good way, sort of, because I had two other cerebral palsy children who presented exactly the same way at around the same time. So my patient would be the first case that you see there. The second case was another child admitted at exactly the same time who was in the room with the baby, and she had tested negative, and after exposure, she also tested negative. So it didn't seem that there was a correlation. There was a pediatrician who, I presented this case to a number of pediatricians, and there was a pediatrician who had a child with vomiting and presumed aspiration who died. She was in a community where there was a cluster of cases, and she became concerned that her baby died of COVID-19. So we got the family tested, and they also tested negative. The reason why I'm illustrating this case is that to show that children with cerebral palsy and bulbar palsy are vulnerable. They can't cough, they don't swallow very well, and they are at risk for respiratory infections, and COVID-19 was complicated by the underlying problems that this child had. So in general, most of the children will have fever and cough, as our cases demonstrate, and as Ayana pointed out, they may have upper respiratory symptoms, GI symptoms, fatigue and headache, and tachypnea and hypoxia in severe cases. In the US, in a large study, the demonstration of symptoms show that the prevalence of fever is much less than in adults. About half the cases of kids have fever, and the other symptoms are much less prevalent, the coughing, etc. More symptoms that can present are myalgia and abdominal pain, which were not present in some of our kids here. But just to say that the children usually do not, fit into the box perfectly, and their symptoms might go unnoticed. Usually the lab problems that we see are decreased white cell, lymphopenia, deranged LFTs, elevated LDH, as was seen in our patient, and some critical patients have troponin and D-diamond ferritin abnormalities. If you see thrombocytopenia, it's a bad sign, and there are other inflammatory factors that might be elevated. Radiological findings, as in our patients, no abnormality in the early stages of the disease. If you are going to do a CT, there are some classic features, as you know, limited ground glass opacities, and there might be unilateral or bilateral. Management, this is a summary: supplemental oxygen, intravenous fluids, antimicrobials, Tamiflu. Don't give steroids routinely. Look for any underlying comorbidities and manage them. Monitor the patient closely for deterioration and communicate with the families often. If the child does not respond to escalating supplemental oxygen therapy, you're going to need advanced respiratory intervention, preferably high flow oxygen and non-invasive ventilation. If invasive ventilation is to be used, there are specific guidelines to do so. So involve your critical care team early in your patients admitted for pneumonia. In conclusion, the findings from this small case series are consistent with published literature, and as we evaluate the larger cohort, we will determine if the viral shedding is in fact shorter among the asymptomatic children compared to asymptomatic or symptomatic adults. And just to say that we've started collating data across the Caribbean. A lot of our colleagues in every island are looking out for these cases, and we have a standardized way of collecting the data. This is our Paediatric Collaborative COVID survey. Thank you very much.
I'd like to say thanks so much to Dr. Tracy Evans-Gilbert. I know that many persons are just dying to be able to ask their questions. If you could write those questions down or try to put them on the chat. I know that at 71 questions on the chat, we're not going to be able to go through each one, but I'd like to say thanks again, Dr. Tracy. Excellent review of your case series and some good analysis and interesting discussion being generated there. Thank you. Our next presenter is Dr. Gayatri Kupsami, and he hails from Guyana initially, where he did first his bachelor's and then his medical school. He was initially at the West in Jamaica. And then he's joined the pediatric program at the University of the West Indies, MONA. And so at this time, he will give us a toe in to what we will speak about later, which is our multisystemic inflammatory syndrome in children, which Dr. Evans Gilbert, who will come later, will take us into the realms of the case definition and an overview. But as of right now, Dr. Gayatri will share with us this case. Thank you so much.
Hi, good afternoon, everyone, and thank you, Dr. Williams, for that introduction. So we recently saw a case of Kawasaki at the University Hospital, and we thought that we'd share it just to remind everyone that once we see Kawasaki disease during this COVID-19 pandemic, we should think pediatric inflammatory multisystemic syndrome. So this is a case of a 2-year-old female, previously well, had no previous illnesses, developmentally normal. She started having abdominal pains 10 days prior to her presentation to us at UWI. This was shortly accompanied by a fever that was objectively measured by mom. The fever the highest was 102.4 and occurred daily. During this time, she was seen by 2 different doctors, and the diagnosis of a pharyngitis and cervical lymphadenitis were made, and so she was started on antibiotics. Shortly after, so roughly about day 3 to 4 of her illness, she started having a rash that was described as maculopapular. It was generalized and very pruritic. And shortly after, she started experiencing irritability, particularly when the fever came on. She had decreased appetite, redness to the palms, and conjunctivitis. There were no other significant symptoms, really. There were no known preceding illnesses, no known COVID-19 positive contacts, and no recent travel. Though she attended daycare, it was a very small daycare with just about 2 to 3 other children. So on examination, when we saw her, which was day 8 of her illness, she was definitely febrile at 38.5. Mildly dehydrated, and we certainly appreciated the polymorphous rash. The bilateral conjunctivitis was evident, it was non-purulent, and though she didn't have the classic strawberry tongue in keeping with Kawasaki, she did have cracked red lips, and the cervical lymph node was greater than 1.5 cm and was unilateral. She had palmar erythema to both hands, but didn't have any evidence of edema to the extremities or no stripping to the skin. So for us, the diagnosis of Kawasaki was clear based on the height of the fever and the duration of the fever and the other manifestations that she presented with. But what we didn't know was whether this was just one of our regular Kawasaki disease or whether this was Kawasaki disease in the context of pediatric inflammatory multisystemic syndrome. So in addition to the labs that we would have done for a patient that we suspect Kawasaki in, we also tested her for COVID-19 and did D-dimers and ferritin. And I've only shared the pertinent labs. And so we can appreciate that this child had an anemia, 10.4 initially, but then went down to 9 on day 2 of admission. She had a leukocytosis and a thrombocytosis. Her initial albumin was 42, but then went down to 36. And both the ALT and the LDH were elevated. So the ECG was essentially normal. It didn't have any findings in keeping with what you might see in a patient with Kawasaki. So she had no heart blocks, no arrhythmias, no evidence of myocarditis. And the echo, which was done, was normal, no evidence of coronary artery dilatation. The ESR and the CRP that you're seeing here, I must say that they were done after she received IVIG therapy, and that's because of intricacies surrounding some of our lab tests for patients that we suspect COVID in. But nevertheless, we can see that that ESR was appreciably high. The D-dimer came back at 970, and we know that the upper limit is 500, and the ferritin was just 8 above what is normal. And based on the case series and the observational studies that have been coming out from the UK, they have been seeing a lot of cases of Kawasaki-like disease and Kawasaki shock syndrome. And though there is no distinct number that they can identify in terms of the elevation with D-dimers and ferritin, what they know so far is that these inflammatory markers can be mildly elevated or they can be alarmingly high. The troponin for our patient came back normal, and it was no surprise to us that the COVID-19 NP swab and the COVID-19 IgM both came back negative. And just to refer to another recent study coming out of Bergamo, Italy, which is the epicenter of COVID-19 in Italy, they have been seeing quite an upsurge of patients with Kawasaki-like disease and Kawasaki shock syndrome. And despite their large numbers, only about 20% of their NP swabs actually returned positive. And these were patients that were actually tested twice. I have referenced the articles that I'm referring to on my very last slide. So we do plan to do her COVID-19 IgG, and that's recommended to be done in the convalescent period. So our patient was managed with IVIG, and that was given within that window period, which we know is day 8 to 10 after the fever onset. She was then started on aspirin, the high dose, and subsequently tapered to antiplatelet dose after being afebrile for 72 hours. Even though Kawasaki was our main diagnosis, of course, we had to rule out sepsis, particularly staph and strep. So she was started on empiric antibiotics. And because she was a stable child, most of her management was supportive and symptomatic. So did our patient meet the case definition for, I'm sorry, Dr. James, you missed one slide. Right, thank you. So did our patient meet the criteria for PIMS? So yes, she did have a persistent fever. There were evidence of inflammatory markers being elevated. And if we were to take into consideration her dermatological findings and that history of abdominal pain, we can say that there was evidence of at least one organ dysfunction. We were able to exclude microbial cause, so our cultures returned negative. However, our viral titers are still pending. And as we know, the SARS-CoV-2 PCR may be positive or it may be negative. So the truth is, we may never know whether this child really was just one of our regular Kawasaki disease or whether she was in the context of PIMS. But the learning point for us and for all of us to take home is that if we see Kawasaki disease during this COVID-19 pandemic, we must think of pediatric inflammatory multisystemic syndrome. So just as how in Italy and UK, they're seeing a 30-fold increase in their Kawasaki-like disease, a similar outbreak in any country is expected where that pandemic is present. So in Jamaica, we may see an increase in our numbers of Kawasaki disease. And we also should remember that the clinical and the biochemical features of patients with Kawasaki disease during this pandemic may differ from what we historically know it to be. Certainly in centers in UK and Italy and US, they're seeing a lot more cases of multi-organ dysfunction and multisystemic inflammation. And we should also bear in mind that in the acute phase, both the nasopharyngeal swab and the IgM can be negative, and we know that the swab is only about 60% sensitive in some amount of patients. It is recommended that the SARS-CoV-2 IgG be done during the convalescent period, and this can be done even after the patient has been discharged. So once this test is available to us, we will definitely test her for this. And when we see Kawasaki, we should think of it not just as Kawasaki, but on a spectrum. So is this Kawasaki disease? Is it Kawasaki-like disease? Is it Kawasaki with shock syndrome or Kawasaki with cytokine storm or macrophage activation syndrome? And the importance of being able to put them on a spectrum is that we can investigate early and treat appropriately. Some children may respond nicely to IVIG and aspirin, like was the case in our patients, or some patients may require ICU support, the use of inotropic agents, or even adjunctive steroids in other parts of the world for those patients that are resistant to IVIG and present with Kawasaki-like illness or PIMS. They have been using methylprednisolone. And then there's some children that might require the use of biological agents. So most importantly, though, we just want to think of Kawasaki during this pandemic in terms of PIMS, so that we can, as much as possible, try to prevent any adverse or fatal outcomes. Thank you.
So thank you so much, Dr. Gayatri. Very interesting. Thank you so much. All the very best in the near future and beyond. So it's interesting. You would have heard about PIMS, and then we're hearing about MIC. And so which one will it be? Certainly Kawasaki seems to be or Kawasaki-like presentation seems to be a common way in which a patient may present. And so we will speak to the cardiology perspective, lessons from Kawasaki later. But just before we do, I would like for us to remember that the exposed newborn is definitely one of the subsets of children to be discussed, to be thought of, both because of their own vulnerability as well as their potential for transmission. And so I would like to invite at this time, and help me welcome, our Dr. Blondell, who comes to us from the University of the West Indies, Mona, where she is a senior lecturer. She pursued her training at the University Hospital of the West Indies at UWI Mona, where she did her DM in Peds and a fellowship in neonatology at the University of Toronto in Canada. She is a consultant pediatrician and neonatologist now in the Department of Child and Adolescent Health at UWI. Please help me welcome her. She speaks to care of the COVID-exposed neonate. Dr. Blondell, over to you.
Good morning. Are you hearing me?
Yes, it's actually afternoon now.
Oh, afternoon. Sorry about that. I want to thank you for inviting me to participate in this webinar. And I'll just go ahead and speak about our neonates. Go ahead. So what I'll be looking at today is just an overview of COVID-19 in the neonates, and to introduce to you the Ministry of Health and Wellness interim guidelines in how we should manage, or the suggestion to manage these neonates during this pandemic. And also to a special look at the care of an unwell, exposed, or COVID positive neonate. Go ahead. So before I started, in terms of the overview, most of the literature that has been produced look at children in general. And because most neonates don't really take up a lot in terms of the amount of newborns that are affected by the SARS-CoV-2, the virus, we have very little information. There's a paucity of information about the neonates. But I want to look at two studies that I found that I thought was interesting, and just basically honing on the aspect in terms of the neonates. So the first study that you should be seeing is one that was done. No, you need to go back, doctor. It actually was published in the Paediatric Infectious Disease Journal. It was supposed to be sent out in June, but it was sent out early, a special report by Zimmerman and Curtis. So they did an 11-case series with 2 case reports, and they had 333 children with confirmed SARS-CoV-2 infection. But just to specify on the neonates, they had 9 case series and 2 case reports describe outcomes of maternal SARS-CoV-2 infection during pregnancy in 65 women, and with 67 neonates were delivered. 2 of the mothers were admitted to the intensive care unit. Fetal distress was reported in 30% of the pregnancy. 37% of the women delivered preterm. And the neonatal complications that were found in these women, in terms of the babies, the mothers who were COVID positive, that they had respiratory distress or pneumonia, low birth weight, DIC, asphyxia, and 2 perinatal deaths. They were not alluding to the fact that they thought it was due to the COVID, to the virus, but basically that mothers having an infection can predispose to that to these babies being delivered with some difficulty, especially premature deliveries. Next, Doctor. So for the 4 neonates who were confirmed in this series, 1 was healthy, 3 had pneumonia, of the 4 that were COVID positive, and they were basically checked on day 2 and day 4 of life by nasopharyngeal and anal swabs. In addition to these 4 babies that actually confirmed by PCR, they had 3 neonates whose mother presented 23 days were COVID-19 infected. And when these babies were delivered, they actually found antibodies, immunoglobulin M and G, against the SARS-CoV-2 at birth. So what they're basically saying, despite strict infection control and preventive measures during delivery and separation of the mother and the neonate, they could not rule out that this baby got, there was vertical transmission. Next slide, Doctor. The other study is one that most persons would be familiar with. It's on the PAHO site in terms of, and was in the Journal of Public Health by Duran. And this basically, again, comprised of 222 neonates whose mothers were suspected or confirmed SARS-CoV-2 positive perinatally. Of the 222 newborns, only 13 were reported positive for SARS-CoV-2. Most of the studies, as was mentioned before, in children, the neonates were asymptomatic or had mild symptoms, and most had no adverse perinatal outcomes. Only 2 of the papers mentioned babies who had moderate or severe clinical characteristics. So 9 of the studies reported images suggested of respiratory involvement where there was pneumonia, increased lung markings, thickening, texture in terms of the lungs, and high dense nodular shadow. And there were minor, in terms of the biochemical studies, there were just minor changes. And breast milk, placenta, other areas were tested that were all negative. And they were basically saying that these babies were mild, breast milk was not affected, and so that should be encouraged, and they could not confirm or deny vertical transmission. So I chose these 2 studies because they gave up, these are studies that looked at many studies over a period of time, specifically looking at neonates. So now I basically want to discuss what the Ministry of Health, next slide, Doctor. The interim guidelines for the, because we have very little data, as you can see, what we have been put together in the management of the neonate during this COVID-19 pandemic. So these guidelines were put together looking at the CDC, American College of Obstetrics and Gynecology, what they have put out in terms of care, the American Association of Pediatrics, and from the National Perinatal Committee. So what we did, basically, I'm going to start from the top. Go ahead, Dr. Brian. So I want to start off by mentioning what has been mentioned before. Most of the I think the primary transmission in terms of the neonates is thought to occur from respiratory droplets. And this, I think, is used from during the postnatal period, when neonates are exposed to mothers, other care visitors, the caregivers, visitors, or healthcare personnel with COVID, who are infected with COVID-19. So when these babies, you have to remember, I have to put this in personal protective equipment, and it varies depending on the contact you have with the baby and what you need to basically present with when you actually have to attend to a newborn who has been exposed or is COVID-19 positive. Next slide. Now, we started delivery room management, and I'm just giving the guideline in terms of what the guideline important areas, and it will be available online. But what you have to remember that the neonatal clinician does not need to attend every delivery if the mother is COVID positive or suspected to be COVID positive. The hospital should stick to the normal center-specific policies. Yes, the clinician needs to be there to accept the baby, but unless the baby is showing signs of distress, the physician doesn't need to be in the room. And this is better for the healthcare worker. So a mother being COVID-19 is not an indication that you should be in the room. If the baby requires stabilization, the clinician would, of course, protect themselves in terms of the personal protective equipment. And the major cause that they're in a room now with maternal virus aerosols, You're going to might have to do a procedure on the baby where there's to intubate, give oxygen, bag and mask with positive pressure, ventilation, suction. Aerosols can be generated, so you have to protect yourself. But one of the things you have to remember, even if an infant or newborn is exposed, you have to follow the neonatal resuscitation guidelines and stabilize the newborn. So it's still not an indication to rush a baby from one place to the next before stabilizing this baby. Your primary role is to stabilize the infant and then transport to the designated area. Now, once this baby is delivered, the ideal setting for a healthy, we're dealing with a healthy baby initially, is ideally we'd like this baby to stay with the mother or the newborn, but sometimes you have to consider temporary separation if the mother is very ill, in a more serious illness. The mother is coughing, having a lot of respiratory symptoms, and it's in the best interest of this newborn to be separated on a temporary basis, and this would help to reduce the risk of transmission to the neonate. And this actually should be discussed with the mother, if possible, prior to delivery, the options of rooming in or separation based off her clinical symptoms or presentation at the time or prior to delivery. So infants that are born who are near term or term, there should be designated areas already in the hospitals in terms of where these babies are going to be kept, and they really should not be in the same area as an unaffected newborn. They should have their bath as soon as possible after birth to remove the virus or the potential that is on the skin that could be a problem. However, if this is not available, then it should be ensured that if there's an overflow of babies, then the newborn should be at least 6 feet apart. And they should ideally be placed in isolates, not bassinets, which are air temperature controlled, which will control the possible passage of or transmission of the virus if they're infected. If a mother, however, chooses, she's mild to moderate in terms of her symptoms, and she chooses to have her baby room in with her, and the facility allows this, the infant should remain, again, at least 6 feet from the mother at all times. The infant or the newborn should be placed in an isolate, and physical barriers have been found to be, has been recommended. It's also by the CDC, a curtain should be between the mother and the infant in order for greater infant protection. And if mother chooses to breastfeed, the next slide, in terms of breastfeeding, this is something that is encouraged in all babies, in terms whether they're ill or not. But mothers, if they choose to directly breastfeed, then they should have strict preventive precautions, including the mask, meticulous care of the breast, and hand hygiene while breastfeeding. The mothers wish to express the breast milk, then this can be expressed and it be fed to the babies. And the breast pumps that are used should be cleaned using the standard center policies to ensure there's no transmission. Next slide. The newborn viral testing is something that we know, I won't go in much detail, for the SARS-CoV-2 virus and molecular assay. If testing is not readily available, however, because in some facilities, some institutions, depending on what is happening, they may not be able to do this test. And so clinical monitoring should occur for these babies. So for each one of these tests, you should consider what should be done is that to use one swab in which you do the throat first, then the nasopharynx, and this helps to conserve swabs on the PCR testing reagent. So you place it, and this is placed into a viral transport media tube and sent to the lab with one instead of doing 2 separate swabs. Next slide. And the molecular assay, and this was put up by CDC recently, is that should be done at 24 hours of age and 48 hours of age. So it should not be done at birth because the yield of getting a positive result is higher at this stage. So it should be done at 24 hours and 48 hours. And there have been reports that babies have become positive up to 72 hours after delivery. If rectal swab is available at your institution or at your center, this can also be done, and this should be placed in a separate transport media and can be tested if it's allowed. And you have to remember that in terms of shedding, rectal shedding can occur a week after the nasopharyngeal swabs have been negative. has been found in some studies. Now, so for neonates who have been found to be positive, they should actually get the nasopharyngeal swabs done every 48 to 72 hours until they have 2 consecutive negative samples. These are in our well babies. Now, for our well babies who are that are for discharge home and who are positive, they may be discharged home on a case-by-case basis. We have to consider where they're going, the household, and this involves the social worker, public health. And they're followed up by phone, telemedicine, or they come in to be seen, whether it's in the office, a clinic, or a particular area for 14 days. It is not recommended that they should be sent home, or persons greater than 60 years. Those with comorbidities should actually be taking care of these neonates. So we need to find somebody who is healthy and who would be able to properly manage the neonates. Other caregivers in the home should remain under observation because these babies are positive for developing the COVID-19 and should use standard procedural mask is what is recommended. Next slide, please. Next slide, Dr. Brad. Could you go back? I think there's another slide for the well, if the baby is SARS-CoV-2 negative, then this baby should be discharged to care for designated healthy caregiver. However, if the mother has been sent home and is COVID-19 positive, then standard precautions should be put in place. She should stay 6 feet from the baby. She wishes to breastfeed, then this should be allowed wearing a mask and hand hygiene when breastfeeding, but she primarily should not be the main caretaker of the neonate until she has had 2 negative SARS-CoV-2 nasopharyngeal swabs. And of course, public health would be following up this family. Now I'll go on for care for the unwell neonate exposed or COVID-19 positive. And we're looking at babies who come through the A&E casualty and babies who are delivered in the hospital. Now I wanted to start before going into details looking at some information that I found. This is from the CDC website. And what they found is that the signs that are found in neonates are that they present with non-specific. They present with fever, lethargy, rhinorrhea, cough, tachypnea, increased work of breathing, some with vomiting, diarrhea, feeding intolerance, and decreased intake. So just to give you a general idea in which these are non-specific signs that any neonate that we suspect to have sepsis would present with. Go ahead. So most of the cases present like that. There's another study that was in the Italian Journal of Paediatrics that they looked at a literature review, and this was mainly from China. And I got exposed to this paper recently at another webinar that the clinical features of infected newborns that they found, and they again mentioned that it was non-specific and it was mainly respiratory. They had acute respiratory distress syndrome, temperature instability, gastrointestinal, and they had cardiovascular dysfunction. And this was especially seen in the preterm babies. And in terms of the diagnosis, the PCR in these babies were confirmed, and what they found in terms of the laboratory examination, that leukopenia and lymphocytopenia were seen in their newborns were typical. Their C-reactive protein and procalcitonin were normal values. But what they also found was that these newborns had mild thrombocytopenia, they had increased creatinine kinase, alkaline phosphatase, alanine aminotransferase, aspartase, and lactase dehydrogenase. So there's liver involvement and other areas that they had high results in. From their CT and X-ray, they saw the classical features of some which were mentioned before: the ground glass opacity, the multiple bilateral, lobular, and segmented consolidation. And in particular, in their newborns, they had peripheral lungs. So we have an idea, although there's few in terms of the studies, what we can look for in order to help us to make this diagnosis. Now, if this baby comes into you, this baby has to be admitted to a nurse or isolation area, depending on your hospital and what the facilities you have available. Ideally, it's preferably in a negative pressure room in case of aerosol generating procedure with droplet and contact precautions. Neonates, as I said, is non-specific, and this could be a bacterial infection. So all babies who are admitted need to have a full septic workup to rule out a secondary infection in case the baby has that. And it involves a complete blood count to differential your blood culture. And if the baby is stable enough, you go ahead and do your LP, with the cultures, the urine stain, and of the arterial blood gas, depending on the presentation. Urea and electrolytes are important, especially in babies coming from the community that might have signs of dehydration or abdominal signs. And for the other babies in hospital, might be a day or two after. I put this in italic in terms of this because it's not available everywhere, depending on institution, but they actually recommend it, especially if the babies are coming from the community, that you should do influenza and RSV testing, because this is something that they could have acquired and could be the cause of their respiratory symptoms, to rule out other causes. The chest radiograph and abdominal radiograph as necessary, and the chest x-ray, sorry, that's a repeat, it's there already, but the CT of the chest, this is something that might be important in a baby that is not responding that the way, or you're very suspicious of if the baby is not resolving. So if you do the chest x-ray and you're concerned, if the baby is stable enough and it's not available in all institutions that the baby can get a CT, you could actually see the classical symptoms, as I mentioned, in a lot of COVID-19 pneumonia, which would be helpful, even if the baby comes back being COVID-19 negative. Now, antibiotics should be commenced as soon as possible, because again, it's non-specific. So the baby should be started, if it's a baby that was delivered in hospital, perinatal sepsis or infection, you start with your first line antibiotics. If it's a community, a baby that comes in at day 10, 11, within that period, then you have to cover for community acquired infection as well. So this depends on the policy or what is done in your hospital. Now, the C-reactive protein, as we mentioned before, should be done at 24 and 48 hours. These are specific, but it's a late marker. Some hospitals do it as early as 6 hours, but I think the ministry and from we have suggestion to do it at 24 and then at 48 hours. And as mentioned before, the PCR swab should be done at 28 and 48 hours. And of course, feeding of the neonate should be discussed with the parents, especially with an unwell baby who needs protection. Now, I found this article, which I thought before I go on any further, which is very important in terms of how we look at a baby who we think is COVID-19 positive person. So there's no specific, and this was in February from the Journal of Medical Virology, there's no specific drug treatment for SARS-CoV-2, being similar to MERS, CoV, and SARS. The management is symptomatic and supportive care is the mainstay of therapy for newborns or neonates who has a SARS-CoV-2 infection. So in terms of the oxygen, if the baby requires oxygen, you ensure that you give sufficient oxygen. You manage the electrolytes with the UNEs if the baby is dehydrated, and your ABG in terms of managing the acid-base balance. And one of the important things I mentioned is that you have to be careful in terms of newborns or the neonate, because pulmonary edema could actually worsen the neonate's condition, especially with lung involvement, requiring pushing them over to require more in terms of ventilation or requiring further assistance in terms of their respiratory function. From their study, their babies with acute respiratory syndrome, they found that high-dose pulmonary surfactant played a role. They used other methods, inhaled nitric oxide, high-frequency oscillator ventilation, and extracorporeal membrane, which is something that's not available in a lot of our institutions, but this is from their study. But currently, there are no antiviral drugs for the treatment of a COVID-19 neonate. Next slide. So if a baby ends up being COVID-19 positive, you manage the patient based on clinical and investigation findings. If the baby requires the oxygen in terms of the ventilation, the baby was initially well and starting to show signs of respiratory distress. If you're not in a facility that is able to offer ventilator support, the baby should be referred as soon as possible. If it's in your institution, then you can start with non-invasive ventilation and then progress accordingly. The baby requires mechanical ventilation and manage based off your investigations. You consult with an infectious disease specialist. You don't necessarily have to be at university. We can call Prof. Chrissy, she's readily available if you want to ask her opinion in terms of a baby that you might have in your institution. And of course, you need to practice the droplet contact precautions in these newborns. And it's really recommended that these babies should stay in hospital until they're COVID-19 negative. Next slide. So if the mother, now we're looking at another situation, the mother is positive and the neonate is negative. This is still a baby who is unwell. You manage the baby's underlying condition. You practice your droplet contact precautions, and you have the option, this baby has been treated, has been negative, but mommy is positive. You have the option of the baby remaining in hospital, being monitored for 14 days, if you choose to keep the baby in hospital. If the neonate is clinically well, after a septic workup, 72, 48 hours, 3-4 days negative, the baby is now well feeding, then the baby should be discharged home, arranged for routine follow-up, and with public health referrals, since the mother being positive in the household, and the measures that I mentioned before to reduce the risk of transmission should be put in place. If the mother and neonate is negative, then that baby should be removed from that area and place, removed from isolation. They should require, still have supportive care, manage the underlying condition with droplet and contact precautions. And once these babies are well, they're managed as any baby with presumed sepsis or with sepsis or presumed sepsis, and subsequently discharged. So I want to thank you for inviting me, and if there are any questions, I'd gladly answer at the end of the presentation. Thank you.
I'd like to thank Dr. Crossdale. For that, a whirlwind of a presentation. I thought it was very comprehensive, and certainly the little baby is not to be left out. I really do want to thank you for having presented, and so we will re-invite at this time Dr. Tracy Evans-Gilbert to come back to us and tell us exactly what is this multi-inflammatory syndrome. Is it the same thing as PIMS? On May 15th, the WHO published the scientific brief, which introduced us to this term really as a way of saying to us that we have to be aware of this presentation. And I'd like to thank at this time our PAHO representative to this meeting, Dr. Marion Bullock-Decas, for having shared that scientific brief with the EOC at the Ministry of Health and Wellness. Certainly an important piece of document to help us understand what is being considered in the global perspective. And so without further ado, I would like to thank Dr. Gilbert for joining us again to speak to the multi-inflammatory syndrome, MISC. Dr. Gilbert?
Thank you very much. Okie dokie. Next slide. All right, so we're going to be looking at this new terminology, multi-system inflammatory syndrome, also known as PIMS, which is a pediatric inflammatory multisystemic disease temporarily associated with COVID. It's the same thing. So what I'm going to do is track the timeline for the evolution of this condition. And then we had 2 centers reporting their cases and their experiences. So I'm going to be just putting them side by side and comparing their demographic, clinical, and lab features. These are in London and New York City. Then I'm going to review the case definitions, because there are 3 that have evolved over the past month from the Royal College of Pediatrics and Child Health, from the Center for Diseases Control, and from World Health Organization. I'm going to put those side by side to show you the differences or similarities. And then I'm going to outline the current recommendations. So as it relates to the multi-system inflammatory syndrome affecting children, we recognized recently that clusters of children and adolescents in Europe and North America were requiring admission to intensive care units with this multi-system inflammatory condition, and it had features similar to Kawasaki that you just heard Dr. Kupsami mention, and toxic shock syndrome. And there are case reports and small series describing this acute illness that presents with a hyperinflammatory syndrome that leads to multi-organ failure and shock. The first case report in a child actually was not from the UK or England, but actually in the US. There was a case report of a child presented with Kawasaki disease and concurrent COVID-19. And this was published on April 7th. It was a case of a 6-month-old female child admitted with persistent fever and minimal respiratory symptoms and diagnosed with classic Kawasaki disease, and she tested positive. But the real timeline started in the UK. The UK first started seeing cases in their general population in January. Then in February, the cases increased. And then towards the end of March, towards April, they started seeing children, critically ill children with circulatory shock and a hyperinflammatory state. And these features were consistent with toxic shock or Kawasaki disease. Shortly thereafter, at the end of April, the Royal College of Pediatrics and Child Health published guidelines on the clinical management of these children. At the time, it was called PIMS-TS, which is the Pediatric Inflammatory Respiratory System Disorder temporarily associated with COVID. And they proposed a case definition. The next week, the New York City Department of Health issued an alert to identify children with the same condition in New York City hospitals. And in that same week, there was a publication of 8 children presenting with this condition. In France and Italy, in about a week after that publication, they reported 125 suspected cases, 65 of which were considered to be MIS-C, and an additional 15 have probable links to COVID-19. And on the 15th of May, WHO and the CDC concurrently published their case definitions of multisystem inflammatory syndrome. Now, is this something new? Is it everywhere? Well, Austria, Greece, and Sweden said I didn't see any cases of Kawasaki disease increase. And in Asian countries where you normally see Kawasaki disease much more than Europe, such as Japan and South Korea, they were not observing an increase in those cases either. Europe instituted an early warning response system and yielded 1 case in Austria, 8 in Germany, and 1 in Portugal that tested positive for SARS-CoV-2 and had features of PIMS or MIS-C, whichever terminology you'd like to use. I think the more updated one is MIS-C. So a few additional cases have been reported through the media in Canada, 12 cases, and Switzerland, 3 cases. The pathophysiology. Now, SARS-CoV can have antibody-dependent enhancement, whereby if you have an exposure to the virus before and you're exposed a second time, there is a hyperinflammatory response. But these children are PCR negative, so it doesn't suggest that they're exposed to the virus a second time. What it seems like, it's a continuum of a disease process, and what they noticed was that the syndrome was occurring about a month after a surge of COVID infections that were happening. So this suggests that the illness is mediated by the development of an acquired immunity rather than by a direct viral injury. Now, I'm going to be comparing the London and New York City cohorts. The London presenter had 37 cases and the New York City presenter had 33 cases. So I'm putting them side by side to see if they had similarities or differences. As you can see with the age distribution, it ranges from a low of 1 to a high of 17, with a median of 11 years in London and 9 years in New York City. There is male preponderance. With respect to the ethnicity, there seems to be increased prevalence among Black, African, Caribbean persons in London, and it was also seen in New York City. In the London population, the general population of Blacks is 13%, and it was 3 times more in the population of persons affected with MIS. Asians are affected, and whites not more than usual, and it's high in Hispanics. In New York, they found a comorbidity with obesity and reactive airway disease, but this was not noticed in London. With respect to the clinical presentation in New York City, neurocognitive presentations were a high of 58% in this condition. The presenters in London had broken down the neurocognitive presentations to headache, meningism, confusion, and neurological symptoms. So it is uncertain if there was overlap, but when I combined all of these symptoms, it came up to 70%. So it might be lower because there may have been overlap with these symptoms. But the main point is that neurocognitive symptoms can present in this condition. Respiratory symptoms were about a third in London. So although COVID-19 is primarily a respiratory disease, it did not present predominantly with a respiratory symptom. New York had about half cases having respiratory symptoms. Both sites had a high level of shock, 75% in the London cohort and 76% in the New York City cohort, and a high presentation, very high, almost 100% of the children presented with GI manifestations in New York. The GI manifestations that was reported in London was 57%, but they also had other presentations of vomiting and diarrhea, which could move this number a little higher. The New York cohort summarized cases that had a complete Kawasaki features as expounded by Dr. Kupsami, and about 2/3 of those patients had complete Kawasaki, and those that had Kawasaki with shock was 75%. They had patients with hepatic involvement, about 1/5 in New York, renal involvement quite high in New York, and about 1/3 in London, and coronary artery abnormalities. There had about half of the children had coronary artery abnormalities, and both sites had a high case of myocardial dysfunction. The London cohort represented the presentation of rashes and conjunctivitis and a low prevalence of swollen hands and feet. So the clinical presentations seem to be similar. The lab features in this condition, in summary, low white cell that we're seeing in COVID-19 in general. They have an increased neutrophil count, may or may not have anemia. They do have increased inflammatory markers and raised D-dimer. As it relates to the definition, the diagnosis of lab diagnosis of SARS-CoV-2, just to say that in London, they did not have their serology up and running around the time, so some of these numbers are not perfect, but just to say that persons presented with both IgG positive and PCR positive in both cohorts. High prevalence of persons were PCR negative and presented with IgG positive later. So Dr. Kupsami's patient with a Kawasaki disease who's PCR negative may go on to be IgG positive when the convalescent sample is taken. In persons who had only PCR positive, that number was low. With respect to management, many of the cases had to be admitted to the intensive care unit, all patients in London and almost 80% in New York City. Both places used intravenous immunoglobulins for management. They also opted for methylprednisolone and in some cases. And then they used some monoclonal antibodies and other anti-inflammatory agents outlined here. But the primary drug of choice was the intravenous immunoglobulin. I noticed that in New York, they were using antithrombotic agents, enoxaparin and antiplatelets, aspirin, was not reported in London, but if you notice their ventilatory support was more in London and their inotrope support. I don't know if they had a sicker population or that they didn't report the enoxaparin and aspirin use, but the New York City cohort said their length of stay was about 4 days. And one wonders if the use of these antithrombotic and antiplatelets helped in any way to do that. There's 1 death in London. Most of the cases in New York were discharged and some still remain in the PICU. Interestingly, the cardiac function at discharge from the New York City cohort showed a mild impairment of cardiac function in a little under 1/3 of the patients, which is concerning. 42% had a normal cardiac function on discharge, but some of them had an impaired that went back to normal. So I'm just going to look at the guidelines that emanated from these two places in London and in the United States. So in the UK, the Royal College of Paediatrics and Child Health gave some guidance for the case definition for pediatric multisystem inflammatory syndrome. And essentially, they had three criteria. The first was that you have persistent fever with inflammatory markers and evidence of multi-organ dysfunction. And you may include full or partial criteria of Kawasaki disease. So the case definition: fever, inflammatory markers, and multi-organ dysfunction. You must exclude any other microbial cause, including bacterial sepsis, staph or strep infection, or infection associated with myocarditis, such as enteroviruses. And thirdly, your SARS PCR testing may be positive or negative. That was their initial case definition. So I put it side by side with the Centers for Diseases Control definition. And the Centers for Diseases Control decided to put an age limit on the 21 years. They have fever, which they said should be more than 38 degrees for more than 24 hours, and also required lab evidence of inflammation and severe illness requiring hospitalization with multisystem involvement. So their core case definition number one matches somewhat with the Royal College of Pediatrics and Child Health. The second is that there should be no alternative plausible diagnosis, which pretty much summarizes what the Royal College has there at number 2. And there should be a positive for current or recent SARS-CoV-2 infection with the PCR, serology, or antigen test, or if there was exposure within 4 weeks prior to the onset of symptoms. So they were more specific with their diagnostics for SARS-CoV-2. And as a rider, they had that you should add Kawasaki disease if some individuals may fulfill partial or full criteria for Kawasaki disease, and they should be reported as well. And they also added that if a child died who had evidence of SARS-CoV-2 infection, you should consider if they had multi-inflammatory syndrome. So I would say that the CDC definition and the Pediatric Royal College aligns somewhat with their definition, with a few minor differences. The WHO considers this syndrome in children with features of typical or atypical Kawasaki or toxic shock syndrome. They give an age range of 0 to 19 years, and the fever actually, they don't, the other two doesn't give a duration of fever. It does say persistent fever in one of the definitions, but in this definition, the fever should last for more than 3 days with the following. They have rash and conjunctivitis or mucocutaneous signs on the hands and feet. They have evidence of shock. They have evidence of myocardial involvement of a coagulopathy, and GI problems. Then they add inflammatory markers and no obvious other causes with evidence of COVID-19. When I look at this definition, it does not involve all of the possible multi-organ involvement. So if the child had neurological, renal involvement, they would not be included in this preliminary case definition. So compared with the others, the WHO definition does seem to be a little bit wanting in terms of being more comprehensive with all of the findings that we saw with the other cases. But these are preliminary case definitions. They probably just went with the evidence that they had at the time, but as more evidence comes in, I'm sure the case definitions will align similarly. So the important highlights are that look out for this in adolescents. It's going to be predominantly in male. These children are going to be critically ill. They're going to be presenting with shock and multi-organ involvement, or they may present like Dr. Kupsami's patient. Very concerning about the high prevalence of myocardial dysfunction and coronary artery abnormalities that were detected in the New York City cohort, where half of the children had this problem. So what does this mean for Jamaica and the wider Caribbean? Well, New York City is a much bigger place than Jamaica, about 4 times as big. And they have seen 147 cases, and they have had, a much bigger outbreak than Jamaica and other islands in the Caribbean. And of course, London is also a very large city as well. Interestingly, the symptoms occurred about a month after infections. So Ayana presented that we had that peak within a month of your symptoms in your various Caribbean islands or in Jamaica, we may see more cases of this multi-inflammatory systemic syndrome. Also, in light of the fact that we're a smaller population, we anticipate a smaller number of cases. However, because there is a Black ethnic predominance, it might present with more cases because our population is predominantly a Black ethnicity. The implications for diagnostics is that we're going to need some serology up and running. If we have PCR negative person diagnosis, we'll need some confirmation with a serological marker. At this time, anti-inflammatory markers that they require are not readily available, but using your clinical features and some simple inflammatory markers like your neutrophils and your ESR and CRP shouldn't hinder the diagnosis. The other thing that has implications for diagnostics is that echocardiograms are not readily available island-wide. And this patient will probably be in an intensive care setting and cannot be moved to another location. So this should not delay intervention. And of course, we wouldn't want our cardiologists jumping all over the place with COVID positive patients. So usually about 2 weeks after, when the PCR is negative, probably there could be a delay, but I'm going to let Dr. Scott address that aspect of the presentation. ECGs can be done to monitor myocardial dysfunction, and definitely an echo is going to be necessary as half of the patients may present with coronary artery abnormalities, but Dr. Scott will tell us when would be the optimum time to evaluate for that. And of course, the implications for treatment is that there's going to be an increased need for IVIG and intensive care capacity. So I'm just quickly going to look at the Royal College's approach to management. Essentially, use your appropriate PPE because this is a COVID positive case. Do your supportive management, empirical antibiotics, take bloods for investigations, which I will highlight, and make sure your cardiologist and ICU are on high alert as you're not sure how the case will progress, because deterioration can be rapid, and to get to an ICU unit, you need to be prepared. So the overall management should be monitoring the saturations, their ECGs, their blood pressure, an early echo if possible, and the timing will be determined by the clinical picture. Look for multi-system involvement, and all cases with suspected myocardial involvement should have an early cardiology input. These are a list of the investigations that should be done: your CBC, ESR, urine electrolytes, LFTs, blood gas if indicated, your coagulation profile. If you have D-dimers, please do so: ferritin, troponin, creatinine kinase, your cultures, your swabs for SARS-CoV-2, ASTO, and serology if available. Your imaging will yield information about a myocarditis, valvulitis, fusion, or coronary artery dilatation. You may find radiological findings on your chest X-ray, and your ultrasound may yield information about hepatosplenomegaly, ascites, lymphadenopathy, or colitis. And if you do a CT chest, if that is available to you, it may demonstrate coronary artery abnormalities if it's done with contrast. Monitoring should be done clinically and laboratory-wise. You're going to be monitoring for signs of respiratory or cardiovascular deterioration, monitor for clinical signs of worsening inflammation as evidenced by fever, cardiorespiratory distress, GI symptoms, hepatosplenomegaly or lymphadenopathy, more rash, or worsening neurological symptoms. And your lab signs will show increasing inflammation with your blood cell counts will be falling, your ferritin will be rising, low or falling ESR, that might be unexpected, rising inflammatory markers, rising liver function, enzymes and LDH, triglycerides and D-dimers, and low serum sodium with worsening renal function. So you're going to be doing a lot of clinical and lab monitoring to see progress of the disease. All children should be managed for suspected COVID. Use your antimicrobials. If they have mild to moderate disease, supportive care only is recommended. And if they're clinically deteriorating, they should be transferred to an ICU. They say to consider IVIG, but Dr. Scott will speak to this, and aspirin if they fulfill criteria of Kawasaki and toxic shock syndrome. And just to say, the information is evolving and there will be updates to this protocol, I imagine. Thank you very much for your attention.
Thank you so much, Dr. Tracy. Again, another whirlwind. I would encourage us to stand and stretch. If we haven't done that, to stand and stretch, because we're in for we're on the home stretch now with respect to the presentations. And at this time, I'm really very, very grateful to welcome our own Dr. Charmaine Scott, who is a pediatric cardiologist, who is known to most of us, whether you're in Jamaica or not, who studied at the University of the West Indies and who studied her pediatric cardiology at Great Ormond Street some years ago. She is well known as a founding member of Director of Chain of Hope, which looks after cardiac care, a charity which is situated in the UK, and they have facilitated the surgeries of many, many children in Jamaica. But she's also known for her work with the children with Down syndrome, of which she has been a foundation person, president, etc. And so without further ado, I really am very, very grateful and pleased to welcome Dr. Charmaine Scott to this forum. Please, Doc, go ahead. Thank you for being here.
Good afternoon, everyone. Thank you to the panelists for inviting me to this webinar. My job is made easy because all the presenters have touched somewhat on what I would have to say. And to start out, I have no idea if Kawasaki and multisystemic inflammatory syndrome are one and the same. However, let's just get right into the presentation. So I'm going to give a brief historical overview of Kawasaki, a summary of the clinical features of Kawasaki disease, cardiovascular manifestations, treatment, and then do a comparison with Kawasaki disease and MIS-C as we know it. So what is Kawasaki disease? Kawasaki disease is an acute systemic vasculitis that occurs predominantly in children younger than 5 years. In developed countries, it remains the most important cause of acquired heart disease in children. The etiology, after all these years, still remains unknown, but it's suspected, based on the clinical presentation, the fact that it is self-limiting, the seasonal epidemics, and the young age of the patients, that it may be an infective cause. There are still no specific tests for the diagnosis of Kawasaki disease. The importance of this condition is that there may be fatal coronary aneurysms in at least 25% of cases that are untreated. Early treatment usually improves the prognosis so that the coronary involvement drops from around 25% to 1 to 3% in treated cases. It is critical that we maintain a high index of suspicion for this disease. What do we know about MIS-C? multisystemic inflammatory syndrome in children affects multiple body parts, of which most importantly would be the heart. We do not yet know what causes MIS-C. Many children had evidence of the virus or had been around someone who was COVID-19 positive. Again, this disease, like Kawasaki, can be serious and deadly, but most children, in fact, who are diagnosed with this condition have gotten better with medical care. So, Kawasaki disease was first described in 1967 by Dr. Tom Kawasaki, who is a pediatrician. He reported 50 cases of a unique self-limited childhood illness and referred to it as acute febrile mucocutaneous syndrome with lymphoid involvement. Dr. Kawasaki referred to it as acute febrile mucocutaneous syndrome with lymphoid involvement and specific deformation of the fingers and toes. This slide gives an idea of the pathophysiology. Children may be infected with an infectious agent, and some of them, a small percentage, do go on to have clinical infection and mount an effective immune response. It is believed that this may be because of some genetic predisposition, and a lot of research is going on into this as to why it is that the small subset of patients who get this infectious agent or super antigen, whatever it is, do go on to recover and do well, yet a smaller percentage go on to get Kawasaki disease. As I said previously, roughly between 20 to 25% of untreated cases. And this will drop to about 1 to 3% if treated. The Kawasaki disease may affect, as I said, some children, but not others. And again, there may be a genetic reason for why some children who get Kawasaki disease get coronary involvement and the others don't. So just a summary slide here of the clinical manifestations and how we go about diagnosing quickly, because you have heard of this in the previous presentations. Fever plus high fever plus any of these signs, which includes the eye signs, the non-purulent conjunctival injection, a rash which may desquamate, and peripheral abnormalities, which involves swelling of the peripheries, lymph node involvement, and a strawberry tongue with dry, cracked lips. Now, how do we make the diagnosis? Well, the typical case should have fever for at least 5 days, and then any 4 of the following conditions: bilateral conjunctival injection, changes in the oral cavity and lips, rash, cervical adenopathy, and erythema of the extremities. Just to quickly mention that in 2017, the American Heart Association revised the guidelines somewhat. Of importance, everything basically remains the same, except that we can now diagnose what we call incomplete Kawasaki in any child 1 year or under who has unexplained fever for 7 days. We should monitor such a child for Kawasaki disease. The importance of that is that we will miss your cases, get them in time to treat appropriately, so prevent the coronary changes. So this is a sign time graph of the clinical manifestations of Kawasaki disease. And of note, the coronary or cardiac involvement tend to lag between the other presenting features. So by the time they get the coronary aneurysms, most of the common features would have resolved or are near resolving. So that sometimes when these cases present to the office, we have to take a careful history because they may not show the classical features as we know it. Here is a slide of the frequency of symptoms. And the important thing is to note that although cardiovascular involvement is only around 20 to 25%, the other features fever, rash, and so on, they will go, but the cardiac involvement, although involving fewer cases, can be life-threatening and permanent. So let's look now at the cardiovascular manifestations of Kawasaki disease. And this is a summary slide. We have coronary involvement, which may be aneurysms or just dilatation. There may be myocarditis. I should say that it is indeed a pancarditis, as it is with rheumatic fever. So there may be a myocarditis, a pericarditis. There may be valvular involvement, quite commonly mitral valve regurgitation. There may be aortic root dilatation, and there may be myocardial infarction. The coronary arterial changes vary from just mild dilatation to giant aneurysms. There may be myocardial infarction and sudden death as a consequence of coronary artery involvement. 50% of the mild to moderate lesions do regress within about 5 years or less, but those with giant aneurysms tend to go on to have coronary issues for life. So, how do we investigate a child with Kawasaki disease? From a cardiac perspective, the ECG remains essential. They may have cardiac arrhythmia. Remember, it's a pancarditis, and so it may involve the conducting tissue. You may get prolongations of your PR and QT intervals. There may be low voltage ECG changes in keeping with a myocarditis or a pericarditis, as well as STT wave changes. The chest X-ray will show cardiomegaly. The echo features at the top of the slide is a section showing a normal coronary artery and the beginning of the main left coronary artery, the circumflex, and the anterior descending, and the beginning of the right coronary artery. In the slide below, the coronary artery is dilated. You'll have to take my word for it, but this here represents the dilated coronary artery on the left with a fusiform aneurysm. The cardio echo findings in Kawasaki disease it's important for us to have a good echo study. And quite often, because these children are irritable by the nature of their disease, it is a challenge to get a proper echo done. The American Heart Association recommends, if you're not satisfied that it is an adequate study, then one should sedate the patient so that you can get an appropriate study and measure, in addition to the other features of the echo, measure the coronary artery internal diameters is what we focus on, and report the Z-scores. The Z-scores represent normal range. If it is more than 2.5, it is definitely, that's the Z-score. In other words, there is dilatation. This is very specific for Kawasaki disease. Note also that when you do your serial echoes, which I will indicate the timing of, if there's a decrease in the Z-score, in other words, the coronary artery measured normal at the initial echo, but you're seeing a decrease in Z-score, that could suggest that there may have been some dilatation. This slide demonstrates a coronary angiogram of aneurysm here in the left anterior descending artery. Here is a giant aneurysm. This is the near normal segment of the coronary artery below the aneurysm. And to my right, this is the right coronary artery angiogram, and you can see that this coronary artery, there's a giant aneurysm here, but also there is some stricture here. So there may be ongoing changes, chronic changes that go on to give some stricturing in the coronary arteries. So this group from George Washington University in 2012 looked at the pathophysiology of Kawasaki disease with regards to the electronic microscopic changes that were taking place in the coronary arteries. And what prompted this study is that we're seeing a varied presentation, and they were not convinced that just an acute coronary arteritis could explain the varied changes we were seeing in this pathology. Their specimens included 32 autopsies, 8 cardiac transplants, and 1 excised aneurysm. And in summary, this slide is very busy, but I will walk you through it. Here is the normal coronary, the wall of the coronary artery. And there are 3 things that can happen after infection or after one gets Kawasaki. There may be no changes, as highlighted here. Or you may get mild dilatation or ectasia, which may resolve within 4 to 6 weeks or a little longer. Or you may get aneurysm formation, and this aneurysm formation is because of a process, an arteritis referred to as necrotizing arteritis. And this can go on to a sort of vasculitis that leads to and progress to changes in the walls of the heart, of the coronary arteries, leading to narrowing and malfunctioning, thickening of the walls of the coronary artery. Now, a word of caution here. When this happens, there may be recanalization to the extent that the lumen of the coronary artery looks pretty normal in diameter. And that's why an echocardiogram may not be sufficient to assess long-term or ongoing damage to the coronary arteries. The third and last route may be you may develop, or one may develop, occlusive thrombus formation in the coronary artery, leading to organization in that over time and predisposing these patients to early onset ischemic heart disease as adults. At this stage, one may get a rupture of the aneurysm, leading to a myocardial infarction. So this is just a summary slide which explains everything I just said. So I will move on to the next slide. So what's the treatment? The treatment recommended is for the acute phase, including the incomplete cases, we treat with IVIG and aspirin. There is debate as to whether or not one should use low or high dose aspirin in conjunction with IVIG, and some of the studies are showing that there's really no benefit in using a high dose, and so some people may just want to use a moderate dose. Steroids is not routinely used, but may be considered in resistant cases, as well as if there is a need to go on to cyclosporine or cyclophosphamide in resistant cases or recurrent cases. So I'll skip that slide because it's very confusing. I intended to show on that slide what are the recommendations for the schedule of cardiology follow-up. And in summary, if there are no coronary artery involvement or there is maldilation which returns to normal, then they will not need the intense follow-up as those who have unresolved coronary artery manifestations. All patients suspected to have Kawasaki disease should have cardiology assessment to include an echo and an ECG in the initial weeks, weekly during the febrile phase, and then at 2 months after onset, even if the initial echoes were normal. If they remain normal at 2 months, then one may stop or should stop the low-dose aspirin, and it's highly recommended that we look at them again at about 1 year after onset. Unresolved coronary artery issues will require intense follow-up at appropriate intervals as deemed on clinical assessment, from 6 months to 2 years to 5 years, depending on severity and involvement. an intense investigation in addition to echo and ECG. Stress testing will be required, cardiac cath, and nuclear medicine perfusion scans. This will help us to assess cardiac function and give advice to the patients, allowed physical activities, and recommended lifestyle modifications. Now, just look briefly at our experience with Kawasaki disease. The seminal study by Professor Pierre and his team looked at 57 cases back in 86 to 99 and found that the annual incidence was around 3 per 100,000, which is low. Number of reasons for that. It may be that there would have been underreporting. Nowadays, we have pediatricians in every nook and cranny of Jamaica, so high recognition case definition. Or there could be some underreporting, as well as in this study, most of the cases were identified from our echo log, and not everybody was coming for echoes in those days on suspicion. So by and large, this is low. Compared internationally as well, in the USA, they're seeing around 9 per 100,000 cases. And in Japan, around 90 per 100,000. So we do have a low incidence in any ways compared to the rest of the world. The late diagnosis, the mean time to presentation was around 9 days, which is towards the end of the recommended period for instituting IVIG. There was a low mortality. In fact, there were no deaths in this series. There's a high incidence of cardiovascular changes approaching around 38%. And this could be because there was a paucity of introducing IVIG for a number of reasons. One, for the cost, it's very expensive, the late diagnosis, and so only 7 of the 57 cases in this series did receive IVIG, and therefore this could reflect the high incidence of coronary involvement seen in these cases. So we had 2 cases with pericardial effusion, and there were valvular lesions. But look, there was only just 1 case with a myocarditis. So myocarditis is rare in our experience, but from the previous speakers, we're seeing where there is in fact a high incidence of a myocarditis in MIS-C. So this slide will compare briefly what we see in Kawasaki disease and what we see in MIS-C. So the patients with Kawasaki disease tend to be younger, under the age of 5 years. We are seeing this condition, MIS-C, in older patients. In Kawasaki disease, we tend to have a systemic vasculitis. As I said before, no single agent has been identified, whereas there's a strong association of COVID-19 with a MIS-C. However, a few of them, as pointed out in the studies, are PCR negative. But then, as was pointed out by Dr. Evans, we probably should consider going on to look at the antibodies during the appropriate period. There is a ethnicity with regards to the Kawasaki disease. It's more common in Japanese children. In our setting, as was pointed out, it's more common in persons of Black ethnicity. In Kawasaki disease, overall, there is a milder cardiac manifestation and fewer patients tend to be affected, whereas with MIS-C, we're seeing a higher incidence of cardiac involvement with more severe presentation involving a myocarditis with shock syndrome. Coronary abnormalities, again, tend to be around 25% untreated, seems to be higher with MIS-C. And there's a wider spectrum of clinical presentation, generally speaking. With MIS-C, we're seeing more GI symptoms, serious GI symptoms, and respiratory association. So, what have we learned from this experience? Well, certainly for Kawasaki disease, early treatment with effective anti-inflammatory regime, which includes IVIG and aspirin, will lessen long-term damage to the arteries of the heart. All suspected cases must have an echocardiogram at presentation with repeated studies to monitor for coronary abnormalities. And if after 2 months of follow-up, there is involvement of coronary arteries, long-term cardiology follow-up will be required for the patient with coronary artery manifestations. And I thank you for your attention.
Dr. Scott, I would like to thank you for your diligence in delivering such an awesome lecture and exposing us to Kawasaki. For some of us whose concentration is with adults, it's a term that hadn't been heard in a long time, and yet the inflammatory presentation makes us wonder, is this like a pediatric sort of lupus or something like that, you know? I'm really very grateful for your presentation. And I dare say that the whole point of this particular webinar was that we would have an opportunity to discuss these inflammatory presentations of COVID and yet non-COVID. The whole point is that the WHO put out their scientific brief with a request for all of us to be aware so that our index of suspicion could be higher and that we have a lower threshold for thinking, could a particular presentation be COVID related in this context? Because the management would certainly be different and the mortality or severity rate higher in a patient who may present with COVID related and yet COVID-related inflammatory situation. So I just really want to say thank you to all the presenters. We have gone through a whole spectrum. We are blessed by our CMO and we've been really gone through a whole spectrum of presentations, not excluding the little ones, the neonates. And we want to thank our epidemiologists for really having started off us on a good footing. But we want to give an opportunity for you to ask some questions. I see many questions. More than 100 questions have been asked. And this is a hard part, I think, because I'm going to ask my co-chair, Dr. Brian James, who is head of department anesthesiology at the Bustamante Hospital for Children, Children's Hospital in Jamaica, to take us through these questions. Lots of questions have been asked. I can't promise that we're going to go through 100, but I do believe that many of them are going to be able to be batched. And so, thanking all the presenters, I'd like to also invite a number of persons, including Professor Celia Christie from the University Hospital, to stay tuned to answering some of these questions. Dr. Brown, over to you.
This question that is being asked regarding shedding in the feces, what happens is that the fecal PCR will be positive for a prolonged period, but studies have not shown that these are viable viral particles in terms of being capable of transmitting disease. So viral cultures that have been done along with these have not proven that these are viable viruses that can be shed. So doing the stool testing would not be very helpful. Or Kim Tat.
Okay, hopefully you can hear me now. Next question is from Dr. Ro Porter. There is actually an answer posted there. However, I would like to find out whether Dr. Wellington would like to elaborate on that answer.
No, that was the answer. Thank you.
Right, so there are people who have wanted to know this. And there is an answer posted there. Dr. Shaw also posted a question. Is Dr. Kupsami still there?
Hi, yes, I'm here. So to answer this question, I'm unsure which kit was used for the particular patients, but I know that they're developing new kits. And as the kits become available to us at UE, we test them. So I know of a particular patient that was actually tested twice with the different kits. But that's as much as I can say at this time.
Do you know anything about the other part of the question? The validity of the test kits? Because some people are saying that the sensitivity may be as low as 30%.
Right. No, I'm not sure.
Okay. Thank you. Thank you very much, Dr. Kupsami. Dr. Evans Gilbert, there is one here for you. Again, Dr. Wellington answered it, but I'm not sure whether everybody saw the answer. Do we want to elaborate on that?
Oh, about the validity, that would be Wellington who would be able to speak to that. Just to say that the children who presented had clinical features that would be consistent with COVID-19 as it relates to the reliability of the test. Dr. Wellington will have to speak to that.
Okay, so as stated there, I'd have to get the precise figures for sensitivity and specificity. I suppose the answer would be more specificity of the PCR test, and provide that to Dr. Nadine Williams for subsequent dissemination.
The questions, let me get them. One person asked about the testing of newborns, whether the mothers are suspected or positive. And what the CDC recommends is that all newborns who are delivered to COVID positive mothers are suspected should be tested, PCR testing at 24 and 48 hours. So irrespective, it's something that is recommended. I think this was asked by it's Henry. Let's see, Henry. So all newborns in a suspected or confirmed COVID positive mother should be tested at 24 and 48 hours if it's available. The other question was asked about exogenous surfactant. This was I saw this in only one study, so it's not something that is generally recommended. If it's a PREM, then yes, you're going to treat according to clinical findings if the baby requires surfactant, but it's not the standard of care that a child that presents with COVID pneumonia, if you suspect that surfactant is given. It depends on what you find and how, and in terms of the clinical findings, that if it's appropriate. This was just a study from China that is how they treat their patients. So it's not something that is recommended routinely. And the final question that was asked was about the delivery, how the babies are delivered, if that has an impact on them actually getting COVID or being infected. I can't remember the study. There was one study that suggested that vaginal delivery increased the risk, but most of the studies have not confirmed that the mode of delivery has any effect in terms of how these babies are actually contact or get COVID positive. So I can't really say for sure that the mode of delivery confirms this, and I haven't seen it in the literature or from any of the sites, referral sites, CDC or PAO. And Dr. Brian?
Yes, thank you.
Yeah, thank you.
All right, so there are a few other questions. One is to find out from Dr. Gilbert whether or not we should follow our confirmed positive pediatric cases for COVID-19 as a precautionary measure. How long should we follow them for?
Children will present with clinical symptoms of this condition and present to their doctors, etc. So, so they will show up if the symptoms are going to manifest. We are establishing a protocol for the follow-up of kids, and we will be able to tell you, what the national guidelines will be, but it's in development currently.
All right, thanks.
Yes.
Thanks a lot, Dr. Evans. There is another question from Dr. Kim Tate. He's asking Dr. Scott, how is sedation performed on the Kawasaki disease patients who have echocardiography? Is it meant to be IV or PO? And is there any increased risk of respiratory compromise?
Dr. Brian, I think you should be the one answering that question.
I thought you would say
Highly
that.
dependent
But clearly,
on availability
these patients, the
and
sedation
compliance of their
depends on
anesthetists.
how compromised their cardiovascular system is. I mean, we tend to go with intravenous sedation, certainly once the anesthetist is involved, which they often are. So this is a more controlled situation. And of course, respiratory compromise is always an issue in those cases, but I mean, if we're there, we're able to address it. We have agents that we use that we do not have that problem with. I hope that satisfies you, Dr. Tay.
Okay. We sing a lullaby or find some other ways if this is not available.
A couple more questions are coming in. Dr. Crosdale again. Do you think that masking up alone without some form of PPEs for the mother is adequate to protect the COVID negative infant rooming in with the mother who is positive?
So in regards to the mother, as you mentioned earlier, that the most likely way that this neonate is going to get the infection is respiratory, because there's been no strong evidence that it's called a vertical transmission. So what they're found, if it's respiratory, then what is important, and of course the hand washing, is that the mother needs the mask. A gown is recommended. That's what's used in the hospitals here, and I figure in other hospitals, the mothers are also wear a gown, and they have to practice in terms of the hand washing and ensure that the breast is properly clean prior to breastfeeding. So hand washing, a gown, and the proper terms of hygiene technique. And that should be enough in terms of trying to reduce the transmission from the mother to the neonate.
Thank you. Sounds reasonable. Finally, I think the final question, I'm going to pose it to Dr. Williams so that she can just segue into her wrap up. And this is a recurrent question that I'm seeing. Good afternoon. Will this webinar be posted for persons who are unable to attend? And are there CMEs that are associated with this conference? Over to you, Dr. Williams, to let us know that.
Good afternoon, everyone again. I just first of all want to say thank you to everyone for having attended this webinar. Unfortunately, CMEs will not be applied to this webinar, but I will certainly investigate the likelihood that it will be applied to future webinars, because this is not going to be the last. Secondly, the webinar is being recorded, and I do believe that our participants will be very happy to share their presentations. And we will certainly try to make the webinar available to those who were not able to attend today, so that you will be able to access the very valuable information which has been shared today. This afternoon's meeting saw the blessing from the CM1 welcome, but it also saw us delving into a number of areas. The fact that this webinar was case-based really allowed us to tease through some of our different approaches while we were fed with prepared presentations and certainly or fund of knowledge has been broadened, I think it is very important that each one of us leaves this webinar empowered to the understanding that whereas we had a sense of comfort before, thinking that children weren't really affected or involved and that the babies were absolutely immune, that in fact children may be vulnerable, and some even more vulnerable than others, and we should pay attention to these vulnerable ones. That the adolescent may actually present with a post-inflammatory disorder because of the heightened immune response to the presence of COVID. And in fact, that we really should be trying to see how we can recognize these persons so that their management can be more appropriately applied. And that children who may be anemic, lymphopenic, lymphocytopenic, etc., inflammatory disorders around the mucocutaneous hand, foot, mouth, in this context, that we apply what we've learned today. The fact is that our protocols locally does speak to our sampling of cases, SARI and ILI, but it also speaks to ultimately the sampling of all hospital cases within a few months, so that we will be able to apply that. Certainly, children who are more ill, people in the HDU, the ICU. So we will need to pay attention to our sampling protocol, as well as our discharge and follow-up protocol, which speaks to, at this point in time, a 7-day follow-up after discharge by the health department, and a 14-day follow-up by the different hospitals and facilities from which a person had been attended. That includes vital signs, a clinical checkup, but it also includes, in cases where appropriate, an ECG. Dr. Tracy Evans Gilbert listed a number of challenges that we will have, because we will certainly not only have to have a higher index of suspicion, but we'll have to have provisions for the fact that the child who's presenting a few weeks, a few months after their initial presentation may have some of these disorders. And so our ECGs, our echoes, etc., we will have to see how we can ensure that where necessary, these provisions are actually available. The fact that we may have to be considering the use of IV immunoglobulin, at least we'll have to think about how do we ensure and that this is available. And certainly, whilst we have not been subject to the onslaught of the very severe cases and at the rates that we have seen from some of our global partners or other countries, we certainly are still at the place where we have to increase our capacity to ensure that we have space and the functional capacity for patients who will need ICU, HDU care. And this is not only going to apply to our adults, but our children. And so today we have really had a very rich time, I think. And I would just like to say thanks again to everyone who made themselves available to come today. It doesn't stop here. And we will certainly be ensuring that for the future, we will be able to apply the CMEs, and we will be able to and as of this webinar, we'll be able to make sure that the webinar is available. So again, I would just like to close off by saying thank you so much for coming out on your Sunday afternoon. In Jamaica, it's just a few minutes before curfew. And so I want us to say get home safely if you're not at home, or stay in where you are. So all the best for the weekend. And again, good afternoon. Goodbye.
Goodbye, everyone.
Bye.
Bye,
everyone.
thank you. Have a nice evening.
Thank you.
Thanks, everybody. Well done.
Thank you, Doc. Thanks, everybody.
Bye, thank you.
Thank you.
Bye, everyone.